So let's get back to these cases. Our gentleman is, we've seen his labs. This is a man who has ulcerative colitis. He had been hospitalized, but now he's in a clinical and endoscopic remission. Presents with a mild anemia, hemoglobin of 11, hematocrit 33, platelets 450,000. He's microcytic, as Gary was discussing, and probably an inappropriately low reticulocyte count. His serum iron is ferritin is 18, 12% saturation. Serum iron is 45, and his CRP is normal. Gary, do we need any other tests in this individual?
I think you have all the testing you need to really define the nature of the anemia. I don't think that you would need other tests, because ulcerative colitis, we're not talking about Crohn's. We certainly would want to get a vitamin D level in clinical practice as well at some point, because we know vitamin D levels are healthy for individuals, and there's small investigator-initiated trials that show benefit for active disease. But I think in general, this is a pretty standard case that you'd see in the office, and I wouldn't think that there are many other tests at this point in time. Certainly in the future, you want to get others.
But you would define him as having?
Iron deficiency anemia.
Okay.
And the reason is because your ferritin is low, you have inactive disease, so this is a patient in remission, the CRP is low, and the transferrin saturation is 15% or less, so this fits the iron deficiency anemia scenario.
And Ed, inactive ulcerative colitis, clinical remission ulcerative colitis, iron deficiency anemia straight up, how would you manage him?
Well, I first ask him if he has any history of intolerance. Has he ever taken iron before? If he hasn't, or if he says, yeah, I can tolerate iron, I typically would start with just one oral iron tablet a day. I typically use ferrous sulfate. Sometimes I'll use that in combination with vitamin C, and I might just start one a day. His anemia is relatively mild, so I think you could start low and work your way up. But if he gave me any history of intolerance to oral iron, then I would go with a parenteral iron product.
All right. So just for reinforcement, Gary, where is oral iron absorbed?
So it's taken in and it's absorbed the duodenum and in the proximal jejunum through the enterocytes.
So back to Ed. Some of the oral iron formulations, you talked about your preference is iron sulfate. One of the formulations you mentioned is the polysaccharide complex. It's a high-dose iron formulation. The polysaccharide does what? Why is it in a polysaccharide? It delays the
right. I mean,
absorption.
it's right. So it's a sort of a delayed release enteral type.
So
delivery.
a number of years ago, I thought that this high-dose oral iron would be a great formulation for our patients, because it was one pill versus, that had 10 times the amount of iron that the iron sulfate had. But it appears that it turns out that it bypasses the place that iron is actually absorbed, approximately in the duodenum. So I don't know, are you aware of any studies comparing those different iron formulations? Gary?
Not offhand, but it's interesting to note how Ed said one a day. And many people, I'm sure in the community and in academics and elsewhere, practice with TID dosing. And as you go up with the frequency, you get more side effects digestive-wise, if you would, but you really just need 325 milligrams once daily.
Now, in the graph that showed the compared oral iron to iron sucrose, you showed that for the first 2 weeks there was no difference with either one, and then the sucrose jumped up. Why 2 weeks? What's the delay in increase in hemoglobin?
I don't have a great explanation for that physiologically, but it may have something to do. You wonder about adherence, things like that.
Well, I think that both took 2 weeks. The point being that it takes about 10 days before you're going to start to see an elevation because it takes time to absorb the iron, process it, and actually build red blood cells. So the point is with either oral or IV iron, don't look 5 days later. You're not going to see a significant jump. It takes about 10 days before you're going to see any change within that.
And Steve,
so
if we
one of
look-
the questions was how long do you wait after giving oral iron to reevaluate the parameters? It's at least 2 weeks.
Yeah, in the clinical trials, the endpoint, if you look in the iron trials, is 2 weeks for a response. And that's the time frame that you'd expect in clinical practice as well. It's not wrong to check it more frequently depending on the scenario, but if it starts going down, you're going in the wrong direction.
This is something I'm unfamiliar with, and a question from the audience, which says that a recent up-to-date article suggested treating with every other day oral iron. I'm not familiar with the rationale for that.
It depends on the severity of the anemia. And if you have someone that has more moderate anemia, that may not be as smart to do because it's really, your body is efficient at taking up iron and it will adhere to, it'll take it up very well and it won't dump as much. But if you remember what I pointed out, how little it's absorbed, 1 to 2 milligrams a day is really absorbed. So if you give too much and it overloads the system, you don't necessarily need it. But I think it's a matter of the severity and the acuity of the situation is totally variable.
And from a pediatrician, says that used to seeing a dose of 3 to 6 milligrams per kilogram of elemental iron for iron deficiency anemia in kids. Is this different in adults? So let's calculate 5 milligrams in a, how much do kids weigh? 20 kilos? So that would be 100 milligrams of oral iron. It's a bit more than we actually would give with adults.
Yeah.
If it has 60 milligrams in the 325 iron sulfate, right?
Yeah.
I think that was.
Yeah, and I think the theme we keep going back to is you don't need a lot of oral iron. If a person has normal duodenal absorption, you don't need. Again, that's why in my practice I rarely give more than 1 tablet a day of oral iron because I think you're just going to see more side effects if you try to give more.
And there's a limitation of absorption,
Right.
even in healthy individuals. Okay, on to the next case. This is the young woman.
So
with,
Steve, can I make a point on the first
Of course
case?
you may.
The other thing I mentioned was this is not the only thing you do. You want to see the response of the patient to the iron. So at least 2 weeks you want to check a CBC and then repeat iron studies in, say, a month or so to see if it's persistent and it's adequate, and ensure that that patient stays in remission and perhaps 6 months later to recheck. So it's important to keep an eye on things once someone does have anemia to ensure their body stores are replete and they stay that way.
And I think that goes for both oral or IV iron repletion. We trust but we monitor. We trust but verify in that situation. So this is the young woman with ileal Crohn's disease who had an ileal resection. She's on azathioprine and metronidazole. If you remember, she presents with some anemia symptoms as well as paresthesias. Her white count is 4,000, perhaps reflecting the azathioprine. Hemoglobin is 9, hematocrit 26, platelet count 250,000. Her MCV is 88, MCHC 30, a low reticulocyte count, low serum iron, low serum saturation, TIBC and iron, as you can see them, and again, a normal CRP. Gary, is there any additional information you need from her?
I think the first thing is a history, Steve, that you pointed out, the paresthesias, and obviously that can be caused by many different things. One could have B12 deficiency with ileal disease, so a B12 level or a urinary methylmalonic acid level might be important to look at directly. Plus, you have medication that's associated with neuropathy as well, metronidazole. So I think these are things to consider. You know, less common things, long-standing chronic disease, one thinks of amyloid, though we rarely see it. And then certainly one can have paresthesias with vertebral compression fractures from steroid use in the past if there's impingement on a disc. So again, things in our differential diagnosis come to mind. But those are the first things I would try to address. In addition, you clearly have laboratory parameters that are significantly abnormal, and once again suggesting the presence of iron deficiency anemia.
So just from the clinical scenario, by the way, this is a woman who had an ileal resection. She's got anastomotic ulcers. And what do you think of that? Not pre-anastomotic, but just if it's my wife, tell her I'll be home tomorrow night, late.
So I think this is something that was recently presented at DDW. Jean-Fred Colombel looked at retrospectively those patients that had resection of the ileocecal region and had I0 or I1 lesions with anastomotic ulceration. And they behaved differently as to saying that they had no disease recurrence. It had more aggressive recurrence, if you would, and they behaved sort of those patients that were with recurrence of disease. So it's retrospective, it's limited, it was not large collaborative numbers, but I think it's an important message that we should be looking at these patients in the future, perhaps in a prospective way, to say, should we be aggressively treating these and look more frequently than the standard looks we had done in the past?
Ed, comments on that anastomotic ulcer?
Yeah, I think there's some debate about, there's some back and forth in the literature right now about whether that just having the anastomotic ulcers increases the risk of recurrence. I think the studies are starting to sway in the direction that it does increase the risk of recurrence. And, you could say maybe in this person, should they escalate therapy on that basis? It certainly should be considered. I think this patient has at least iron deficiency anemia, but maybe on top of it something else. And like Gary said, check the B12. There may be some component of chronic disease here as well.
And it's important to note, Steve, as well, that patients that have, let's say, colon cancer and you do a resection, you virtually never see those anastomotic rings.
Exactly.
So it's something specific for IBD, itself. Crohn's per se, more so than, say, UC, where someone has had diverticulitis and they've had a resection or other reasons.
I would just point out that I've seen a number of these patients who present with chronic anemia and continue to need iron replacement, either oral or intravenously. And I think that can cause certainly can cause a gradual leak in those patients.
And don't forget other causes, right? So, I can't tell you how many times a year I see somebody who gets referred for a double balloon and they have a 10-centimeter diaphragmatic hernia and Cameron erosions, and everybody wants to do the double balloon, but fix the hernia and the anemia will go away.
Yes, both of these patients had GERD. Would you stop their PPIs if they're taking it if they're iron deficient? I guess you'd reassess,
yeah, you'd
right?
have to consider
their GERD,
yeah.
because many times in all of our practices, the patients get hospitalized, they're put on IV steroids, they're automatically put on a PPI, and all of a sudden they're on a PPI forever with never reassessment of that. So I think that those are all good points. Along those lines, one of the questions, Ed, is that you're giving iron along with vitamin C. They want to know how much vitamin C do you give with it?
Oh, just the standard, what is it, 200 milligrams or, yeah, it's not, you don't have to give a lot. Yeah.
And then,
but be careful with vitamin C and Crohn's. You don't want to give too much because it can promote oxalate stones. And that's one of the things we always are fraught with. Oxalate kidney stones are things that can come about. So in UC, no problem, and in most Crohn's patients, no problem.
But what about this woman with an ileal resection? She's very disposed to hyperoxaluria as you point out.
So one could do a urinalysis and look for oxalate crystals and then assess. If they're not there, then it's reasonable to consider it, because we often want the patients to get absorption that's on the good side. I think most people would say don't start with vitamin C directly and just try iron. If they need the vitamin C, one can do it. If they're on a PPI, then I think you need something like a vitamin C.
I guess we're perhaps in a post-physiology phase of practicing medicine, but I remember being on the wards, and if I had a medical student on the wards and I had a patient like this who was anemic, who had a hemoglobin of 9, I would ask that medical student, how much iron replacement does the patient actually need? And we would go through the calculation of the grams needed, how much hemoglobin has, how much iron in hemoglobin, and hence how many grams of hemoglobin needed to be replaced, how much iron was in there, and how we would administer it. Nowadays, when you're giving IV iron, are you calculating an iron need, or are you just administering? And if
I have
you're
to
just
say that I'm
administering,
not, yeah.
how much?
Yeah.
And then what do you do?
So if I was giving, say, ferrocarboxymaltose, I'd give 750 at a time, and I would do 2 infusions, so total of 1,500. If it's iron sucrose, 200 at a time, 4 or 5 infusions, separated by a week each. And then for ferrimoxitol, it's usually 510, 2 infusions, and separated by at least 3 or 4 days.
Yeah, I think the prior calculation, and I forget the name of it, was primarily because our initial iron, parenteral iron, was iron Dextran, which was given in 1 slug if the patients could tolerate it, and you kind of calculated how much iron Dextran they needed.
Yeah, the Ganzoni equation is what it's called, Steve. And
Thank you.
And
Will you tell us what it is?
It's been shown that it really doesn't represent well what the iron deficits are, and treating, as Ed does, as Steve does, as I do, is just to treat and see how they do is the best way to do it. It's been looked in studies. So I think it's something that's of the past and no longer used in clinical practice.
Back to Ed, can oral iron exacerbate disease activity in IBD?
Well, again, it's hard to sort out because, right, is it just the GI intolerance, or is it actually making the inflammation worse? I'm not sure that we know that, but bottom line is if it's not tolerated, then they're not going to take it. So you have to move on to something else. So I have a very low threshold for just moving to IV iron. I'm lucky because I work at a place where I can literally just send them over to the infusion center that afternoon, and they're going to get their IV iron, and I just order it myself. I don't get hematology involved. I just do it myself.
A question is, occasionally, and you mentioned this, Ed, a low plasma phosphate is observed following IV iron infusion. Do we need to monitor for that routinely?
I don't monitor it routinely, but if I have a patient who is having unusual symptoms after an iron infusion, sometimes they'll have a malaise or fatigue or flu-like symptoms, I might consider checking it.
And can we postulate the mechanism of low phosphate in that situation? I think iron is always given as a complex to either sucrose or Dextran or something. I believe there's probably some binding of the phosphate, serum phosphate, to one of the complexes that may lower it transiently. But it is not something you routinely need to monitor. It's going to be seen more in patients who get a big dose of intravenous iron, particularly iron Dextran in patients. And I think Ed provided the monitoring strategies for the other parenteral formulations that just require a 15-minute infusion and then about 30 minutes of observation for any of the low blood pressure risks or tingling that were actually mentioned. Let's see. Great questions that you all provided. I think that deals with most of the questions. So to sum up, when to screen for anemia, it's obviously in patients who present with symptoms, potential symptoms of anemia, which would be fatigue or palpitations and severe anemia, individuals who present with pallor, but some of the subtle symptoms that Gary mentioned, restless leg syndrome, and the number one complaint of our patients is fatigue, particularly in Crohn's disease. And it's been demonstrated in European populations that the fatigue may actually, and Gary mentioned this, may precede anemia as a manifestation of iron deficiency. So it would be an indication to monitor iron stores as well. And Gary also emphasized the other situations such as drug therapy, such as resection in our patient, that may make them at risk for other deficiencies such as vitamin B12. Folic acid deficiency, we rarely see more since most of our food sources are supplemented. Perhaps patients who are on sulfasalazine, but it's been a good while since I've seen anyone presenting with folic acid deficiency.
So one of the things you're supposed to supplement with, if you use a bile salt binding agent, folate may become deficient, so the cholestyramine or other things, and that might be a scenario where it can come about if you measure it. Most people don't check it.
So the Crohn's and Colitis Foundation now has a care pathway for anemia, begins with an assessment of hemoglobin and ferritin as a, quote, universal screening for patients who are non-anemic and have iron deficiency, which would be defined as an iron ferritin less than 30, assess their iron, making certain that their iron stores are repleted. On the other hand, if they have inadequate iron stores or inflammation, in individuals who are inflamed, the absorption is going to be reduced from oral iron because of the hepcidin mechanism that Gary mentioned, and most of these patients should be treated with iron therapy. Now, that iron therapy can either be oral or intravenous. In patients with inactive IBD, oral iron, 30 to 100 milligrams of elemental iron per day, that would be covered with ED's 60 milligram formulation of iron sulfate. Or if they have active IBD, IV iron, because of the reduced absorption of oral iron and the potential interaction with symptoms. They recommend reassessment, as Gary did, about a month later, not within the first 2 weeks. Many patients, even if they are receiving IV iron, will require maintenance therapy with IV iron. For instance, this woman who had the ulceration at the anastomosis is disposed to more chronic types of anemia and may need long-term replacement. So it has been put within the CCFA care pathway. It is, again, another quality indicator in many of our practices, and making certain that we are replacing iron in individuals with anemia and then monitoring are part of our quality metrics, as Frank Frey and the CCFA and ACG have recommended.